I call this meeting to order. Welcome to meeting number 84 of the House of Commons Standing Committee on Health. Today's meeting is taking place in a hybrid format pursuant to the standing orders. In accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. Pursuant to the order of reference of Wednesday, February 8th, 2023, the committee is resuming consideration of Bill C-293, an act respecting pandemic prevention and preparedness. We are resuming clause-by-clause consideration of this bill. Where we left off, we were at Clause 3 and Amendment CPC 4. Mr. Doherty, please.
Mr. Chair, this should come as no surprise to our colleagues. As you know, the clerk distributed my motion on Monday afternoon to meet the notice period. And at this time, I'd like to move my motion on the opioid crisis. Given that the recent study from the ICES, Western and Lawson Health Research Institute, revealing a lack of housing can influence people's patterns of substance abuse, that the committee recognize, A, the correlation between homelessness and increased opioid deaths. B, while opioid deaths in Ontario increased twofold over a 4-year time frame, deaths among the unhoused saw a nearly 4-fold increase. C, people experiencing homelessness accounted for 1 in 14 opioid-related overdose deaths in 2017 and 1 in 6 deaths in 2021. That the committee call on the government to make access to the low barrier housing a central strategy in its efforts to address the opioid epidemic, and that the committee report this motion to the House. Mr. Chair,
I think you sent it to me, didn't you?
if my colleagues can't guess by now, I take this issue very seriously. And to be honest, Mr. Chair, I don't doubt the motivation of our colleagues either. As I started to say, and before I was cut off a number of times last meeting, I have enjoyed the support and the partnership, if you will. Up to a certain point from our other opposition parties calling on this government to declare a national health crisis, the opioid epidemic, a national health crisis. Last week, Mr. Chair, researchers at Western University in London, Ontario, released the findings of a study on the link between opioid deaths and the lack of housing. I'm shocked at the results, Mr. Chair. I'll repeat the statistics. Homeless Ontarians accounted for 1 in 6 opioid-related deaths in 2021, a staggering rise from the 1 in 14 in 2017. Allow me to read briefly from the study for a moment. In one of the first reports to track the continuous increase in opioid-related mortality in the province among people experiencing homelessness, researchers found that the quarterly proportion of opioid-related overdose deaths among unhoused individuals increased from 7.2% in the period between July and September of 2017 to 16.8% between April and June 2021. On average, that's 1 homeless individual losing their life to an opioid overdose every day, said lead author Richard Booth. Unhoused people are overrepresented among opioid-related deaths, and the situation has reached a critical point following the challenges of the COVID-19 pandemic, end quote, which is why, Mr. Chair, I tried so hard to mention this during our last meeting. Mr. Chair, we know that the statistics show that there are 22 deaths per day in Canada related to overdose. And those are statistics that we know. I often, when I'm talking about suicide, the rates of suicide or attempted suicides in our country, I always caution that with these are the statistics that we know. Like mental illness and suicide, deaths by suicide, there is such a stigma attached to addictions. These are only the deaths that are reported, only the deaths that we know. There are so many more that go unreported. My Liberal and NDP colleagues can no longer ignore this issue. We've been pushing for some time now to move this committee's study on the opioid epidemic. But all my colleagues on the other side of the House, of the table, want to do is shut down this debate. Mr. Chair, I'm curious as to why my colleagues are so afraid to discuss this topic. I've been very raw and very...
Point d'ordre, Monsieur le Président.
Point of order, Mr. Chair.
Un appel à règlement, Monsieur Thériault.
Point of order, Monsieur Thériault. I apologize to my colleague. I was waiting to see his explanation. I see that he's going into the heart of the topic. But I would like to submit an issue that I have with the motion. I hear that it is in order, but the structure of this motion, and perhaps my colleague will also tell me that I'm right. The structure of the motion is based on a study. And it's not translated into French. And so I would have to decide on this motion when I don't have access to the French version of this study. It does not exist. And so, Mr. Chair, I would have wanted for us to have a French version of the study because it's not a footnote here of this motion. This motion is based on a study that I cannot have in French. And I'm sure that my conservative colleagues understand my point of view, and it has nothing to do with me not wanting to discuss this motion. But I think that we could have tried to get that study translated. I think it's only 11 pages. If we could have at least translated the abstract or the conclusion, that would have been a good start. So perhaps you can assess and decide on this, Mr. Chair. And secondly, we already have in the calendar, I have a second point of order.
Raising a point of order, and the first point that he raised is a valid point of order.
Show me.
I'm waiting to hear the second part.
Le deuxième,
allez-y.
c'est que Monsieur...
The second is that Mr. Doherty, in his argument, and perhaps he'll come back on that, stated that the committee wouldn't have the intention to address the issue, even though we all agreed on a calendar, and there is a motion that was considered. It was Mr. Hanley's motion, and it has to do with opioids on December 11th and 13th. That's already on our calendar. And this is a technical question here. Mr. Hanley's motion is much more general. I also read Mr. Ellis's motion on opioids. And I'm wondering if these motions are seeking to replace the one that we are going to be talking about on December 11th and 13th. Could it not be part of one of the 8 meetings that we had reserved? I know that We don't usually talk about this publicly, but we had many sessions to organize our calendar. And tonight, we're told that we want to look at opioids, but that's already in our calendar. So that's what I would like to share with you, Mr. Chair, and I would like to have your decision on both of those technical questions. I think that the second question was that the second one doesn't propose a motion, or a study rather. But the motion is still valid, and it is allowed to ask a committee to declare something and to make a report to the House, and that is what is in the English and in the French. And so the first part of your point of order is clear, and it is allowed. The second part, what was the second part again?
Oui. Ça, c'est le deuxième.
The second part is about a similar motion. We talked about Dr. Hanley's motion, but it hasn't been adopted. And even if it were to be adopted, it wouldn't change anything. Mr. Doherty can still give notice of his motion. The fact that it's on a similar topic does not preclude him from doing so. And so I understand your points, but I will give the floor back. Just a point of clarification. Does that mean that the calendar that we adopted is not official and that it can be changed? Perhaps you can clarify, because on the 11th and the 13th, I see study on the opioids. And so are you telling me that the calendar is rendered worthless once something new is tabled? The committee can change the work plan through a motion, and it is something that has happened before. And for the first part of my question, I know that Mr. Doherty can table a motion, but it is focused on a document that has not been translated. And so it is sharing arguments from that study. So the study from the Institute of Clinical Evaluative Sciences, Western and Lawson Health Research Institute. I tried very hard to read that out properly. That study has not been translated, and I thought that this committee would be more sensitive to the fact that it's not bilingual. So we have arguments here from the study, but it's not translated. And I can't verify all of this and vote on it because it is not translated. So there's something that needs to be considered there. I think that we should have to make a decision on this and set a precedent. It's never too late to do the right thing, and I think that I have the right to participate in this debate. Okay, I understand your point now, Mr. Thériault. You can suggest adjournment of the debate so that you can read the study, but it doesn't impact Mr. Doherty's ability to table the motion and for us to debate it. But I do understand your point. There are a few options here, but it doesn't impact his ability to table the motion. Mr. Doherty?
Mr. Chair, and I appreciate the comments from our
Sorry, Mr. Doherty, just before I've given you back the floor. If you anticipate that we're going to be here for the full 2 hours, I wonder if you might consider asking our folks from Public Health Canada if we're not going to need them that they be free to leave.
Mr. Chair,
If you're not in a position to do that, then don't.
yeah, I at this time I would say no, but
Okay.
I don't want to waste anybody else's time, and I'd like, I probably could be considerably through this by now if that was.
Fair enough. Thank you. Go ahead.
Thank you. I do appreciate the comments from our colleague, and I appreciate your deliberations on this as well, Mr. Chair. Mr. Chair, I guess the question that I have from my colleagues across the way regarding the opioid study, and we have been pushing this, obviously, and raising points of order and motions on studying this, and I appreciate that there has been discussions about the calendar. But there are topics, there are reports that are coming out that this epidemic is increasing. It is becoming more and more prevalent, and I think that causes it should raise alarms with all of us around this table, and I think we should. And there's obvious precedents in other committees where the calendar that has been decided upon, agreed upon by all parties, that it has been changed, and there are topics and bills and legislation or what have you, motions that have been bumped up in the order of precedence. Mr. Chair, I guess the question I have is, are our colleagues in denial that there is an epidemic in the first place? Are they afraid that the so-called safe supply policies will be exposed to Canadians in a public committee? I said it last week, and I'll say it again. This government needs to do better. We all need to do better. Thousands of Canadians are suffering each and every day from this opioid crisis. And this study, the ICES study, confirms what we already know and what we have been saying for months now, if not years. The government is failing to protect the most vulnerable of Canadians. We're talking about people dying. It's not something we can ignore for a minute longer. These people that are addicted to these drugs, the homeless people on our streets, they're dying. We can't ever bring these lives back. We can't give them a second chance, and we cannot keep pushing back the study and adjourning debate whenever opioids are brought up. It is a difficult conversation. Sometimes doing the difficult tasks, while not easy, it's the right thing to do, Mr. Chair. Canadians expect better from this government, Mr. Chair, and this crisis is touching people from all walks of life across our nation. We have this crisis, this opioid crisis, fentanyl crisis, as I mentioned in my last conversation or my last intervention on this. It impacts folks from all corners of society. We have a duty to protect the lives and livelihoods of each and every person in our country, whether they are a homeless person, whether they are addicted, a blue-collar worker who is addicted to opioids. Our homeless population, they don't have a roof over their heads. But many have served our country. Many have, for whatever reason, have fallen into despair. Canada is still their home. Our country is still their home. Surely my colleagues across the table must agree. Maybe they need more convincing. Let me quote again from the study. While opioid overdose deaths in the province increased twofold over the 4-year time frame, deaths among the unhoused saw nearly a 4-fold increase. Unhoused individuals who die were often younger, 61.3% between the ages of 25 to 44 years of age and were more likely to have recently accessed healthcare services for mental health or substance use disorders compared to housed individuals who died. We know that the Liberals and the NDP are politically invested in the success or perceived success of so-called safe supply policies, but surely they can put their partisanship aside for the good of Canadians. I've asked this so many times in the House when talking about mental health and addictions and suicide prevention. Why can't all parties come to an agreement that this crisis demands the attention of this committee now? Not in a few weeks or a month or next year, Mr. Chair. Right now. We can't afford to wait any longer with the lives at stake. And the study goes on, saying this: lack of housing can influence people's patterns of substance use, which can introduce considerable risk for people accessing Ontario's highly potent illicit drug supply. Access to low-barrier housing should be a central strategy. Mr. Chair, will the Liberal NDP coalition listen to these calls to action? As we've seen in this committee in recent weeks, it's proving nearly impossible for them to even acknowledge the crisis at all. So how can Canadians trust that this government will heed the calls of these experts? You know, Mr. Chair, since I tabled my motion last week, the outpouring of messages from families, from loved ones that have lost children. One wrote to me about their 14-year-old. And thanked me for the work that we're doing here. We've done nothing, though. All we've done is raise the issue. And I said that right back to them, as we've just raised the issue. But we have given them hope that something will be done. It is likely that the Liberals and NDP will simply claim that their so-called safe supply policies need to be ramped up to address this issue. It's unbelievable to me how they can stand behind such policies while they continue to ignore and offer no solutions to the massive and very real problem of diversion. You know, I met with the minister last week and I raised this issue. And the minister, I believe, let's just say the conversation wasn't as fruitful as I had hoped. Mr. Chair, we need to act now. We need to put the brakes on this opioid epidemic before thousands of more Canadians are killed. The government needs to act immediately to keep our streets safe, start getting addicts into recovery instead of perpetuating their tragic and deadly addictions. The reality is, Mr. Chair, is that this so-called safe supply is anything but safe. I have here the special report from the National Post called Drug Fail. The Liberal government's safer supply is fueling a new opioid crisis. This is one that I tried introducing to this committee on Monday, yet was not permitted. And I'll read from it. Last December, Health Minister Carolyn Bennett, in an opinion article from the National Post, praised safer supply and defended the federal government's commitment to the program. In Bennett's fairy tale world, there are no concerns about diversion, rising addictions, or debilitating infections. The minister also skipped over the fact that, according to the government's own research, many participants of safer supply programs continue to abuse fentanyl because hydromorphone doesn't get them high. Indeed, we've heard that testimony here. Bennett cited the LIHC's Safer Supply Pilot project in London as a particularly notable example of success. According to the health minister, the program has seen 0 overdose deaths. Yet, addiction specialist Dr. Koivu says she has had patients who were enrolled in the LIHC Safer Supply program and ended up dying of overdose. Their exclusion from official statistics has made her deeply concerned about the quality of data being provided by the government. Did this data fully capture what was happening to the program participants? She said, the patients I watch suffering have to matter. Their lives and experiences are important, but I feel like they've been erased, she said. It's interesting, Mr. Chair, that comment, because when I sit with families, and I almost to a T, the overwhelming comment that we get is, do you even care? Are you even listening? The fact that their children, their loved one, their husband, their son or their daughter, or their wife, their brother, their sister, their mother, their dad, is away, in their mind, now the problem is gone. But as we know, the problem continues and is only amplified. Mr. Chair, this is the heart of the problem. At the last meeting of the committee, I started to read into the record an article on diversion. The title tells the story, Astonishing Amounts of Government-Supplied Opioids Found on Sale on Reddit. It's absolutely appalling. What we're seeing is people getting free drugs from the government.
Mr. Chair, I have a point of order.
Mr. Davies, on a point of order.
Thank you. Mr. Chair, Mr. Doherty moved a motion on Monday that dealt with harm reduction and diversion, and that was dealt with at that time. The motion before us today doesn't even mention harm reduction or diversion. It is explicitly referencing housing. I won't bother reading it, but it quotes a study revealing a lack of housing can influence people's patterns of substance abuse, and it asks the committee to recognize the correlation between homelessness and opioid deaths. That people experiencing homelessness accounted for a certain number of opioid-related deaths, and that we call on the government to make access to low-barrier housing a central strategy in its efforts. While the issue of harm reduction or not may be a valid issue to be debated, that was explicitly the subject of his motion on Monday, not tonight. But I notice that Mr. Doherty is venturing into comments and references to harm reduction and diversion, which is clearly outside the parameter of this motion. In fact, the proof of that is that it was explicitly the subject of the motion on Monday and is not mentioned at all in this. So I would ask that he be called to keep his remarks to the motion under consideration.
Okay, thank you, Mr. Davies. The motion is validly before the committee. It was put on notice. The motion does reference opioid deaths. It does indeed tie into housing. I'm not convinced that he has strayed that far from the motion that he's outside the bounds of relevance, but I trust, Mr. Doherty, that you'll take Mr. Davies' comments into consideration and be somewhat guided by that. But anyway, it's the floor is yours, Mr. Doherty. Go ahead.
Your comments, Mr. Chair. Now I have to find where I left off, Mr. Chair. Mr. Chair, I referenced the article that earlier on about on diversion. The title tells the story of astonishing amounts of government supply of opioids found for sale on Reddit. Mr. Chair, to my colleague in the NDP, when we were talking about the drugs that are being found on Reddit, these are drugs that are coming from those that are homeless. These are addicts that live on the street, and they are taking the government-funded safe supply, and they're selling them to dealers who are then in turn selling them, or they're selling them to kids in schoolyards and perpetuating this problem. And taking the money that they make from that and buying the fentanyl for the higher and stronger high. In any event, Mr. Chair, it is absolutely appalling. What we're seeing is people getting free drugs from the government, and then instead of taking them as the so-called safe supply program intends, they sell them on the street or online in places like Reddit or in the back alleys of our streets or in the schoolyards of our streets. Then they take the money from the sale of their government-provided funds and they purchase stronger drugs from the street to get the fix. I'd like to reiterate a portion of the article from Monday, and I'm not sure my colleagues across the table were paying attention at that time. If you want evidence that Canada's experimental safe supply drug programs have been a disaster, all you need to do is open your laptop or your cell phone and visit Reddit, a popular social media platform. Until very recently, if you knew which keywords to use, you could easily find drug traffickers openly selling tens of thousands of hydromorphone pills, many of them still in the same bottles, prescription bottles, and safe supply bags that they were giving them. And they clearly originate from our Canadian safer supply programs. I have pictures for the record, Mr. Chair, and I'll make these available if any of my colleagues have not seen them. It's shocking. If anybody hasn't seen this, these are thousands of drugs that are being used online, and they're not just staying here in our borders. They're being shipped all over the world. It's crazy. As you can see, one drug trafficker has enough diverted hydromorphone to spell out his entire username with pills. Many photos like this one show the diverted drugs still in the pill bottle from the pharmacy and from their pharmacist to the black market, to the pockets of our neighbors, in the back alleys of our streets, in the schoolyards. Mr. Chair, the story goes on to say, though hydromorphone had once been scarce and expensive on the black market, that has changed dramatically when the Canadian Safe Supply programs began flooding communities with it in 2020. These programs claim to reduce overdoses and deaths by distributing free hydromorphone, an opioid as potent as heroin, as an alternative to potentially tainted illicit substances. However, addiction experts have said that as hydromorphone generally does not get fentanyl users high, the recipients routinely resell or divert their safe supply on the black market. And this has caused the drug's street price to collapse by up to 95% in some markets and fueled new addictions, including among teenagers. I also have presented to this House that the leading cause of death for youth ages 10 to 18 in my province of British Columbia is overdose. Reddit users frequently lauded safer supply for flooding the market with cheap opioids. Many of the posts sell hydromorphone had such titles as check the date, 150 dilly 8 milligram collected thanks to Safe Supply Vancouver, dilly heaven, I love Safe Supply, batch of D8s, around 250 of them, I love Safe Supply, living in the UK getting high off of Canada's Safe Supply, haha, having family in Canada is a win-win all round. In the comments section of these posts, Reddit users openly discussed how safer supply recipients would sell their hydromorphone for dirt cheap to buy fentanyl. Drug users marveled at how Canadian government was giving away hydromorphone like candy and throwing these effers around like Tic Tacs, and that drug dealers were buying literally buckets of safer supply opioids. Mr. Chair, this is shameful. For this supposedly advanced country like Canada, this crisis is a blight on our reputation, our character in the Liberal NDP government. People come here from all over the world because Canada is one of the greatest countries on earth. I think we can all agree with that. If we continue to hand out free drugs like candy, we're going to turn into a laughingstock instead, if we aren't already. So-called safe supply just isn't working. Many of these folks just aren't taking them. They're selling government drugs and buying more. Dangerous drugs that get them more high, drugs that are often toxic, that are killing them. At the very least, these dangerous drugs like hydromorphone should be under stricter controls. Methadone, for instance, an opioid agonist that is used to treat opioid use disorder, is usually dispensed at a pharmacy under the watch of a pharmacist. But these so-called safe supply programs can't even do that, Mr. Chair. These programs are nothing short of an abject failure. I've also testify, or I also brought forth that we have pop-up stores in my province of British Columbia that sell crack, methadone, cocaine, and these pills. Our streets are littered with people that are hurting, and we're perpetuating their addiction. We can't get a roof over their head. We can't get them into recovery, but we can give them free drugs. You know, I was talking with somebody who is an addict, has a substance abuse problem, who watched our health committee on this last week, and said this, lives on the streets, said that his friends that are alcoholics, you know, when they were stopping their or trying to curb their alcoholism, you know, it was absolutely no alcohol. This person is addicted to drugs, yet we still give them drugs because they're not as strong as the drugs that they're with, or they're addicted to. You know, what frustrates me is this should not be a partisan issue. It's very simple. You know, last committee, I was approached at the food table asking what would it take? What would it take for us to end this? You know, stop doing what we're doing. I think all of us know what would take. Let's get to work on this, on trying to find solutions to this. You know, Mr. Chair, it's very simple. This is about protecting our communities from being flooded with cheap government-funded drugs. It's about protecting those who are the most vulnerable, those who don't have a home to go to at the end of the night, those the youth that don't have the life experiences, that don't know what they're getting themselves into. What about the blue-collar worker? You know, in my province, the stories that come out range from those that are in our most marginalized communities, but also you hear stories about the blue-collar workers that are working in camps that start off with recreational drugs. You can't even tell what is in a joint anymore, apparently. There's, you know, I was speaking with an RCMP, and he said that, you know, they found a bag of marijuana and it was laced with fentanyl. So these kids and these people that are going to these whatever parties or what have you, or they think that they're just taking these harmless drugs, or those that are on the street that are looking for that next high, they have no idea what it is that they're taking and how potent it is. You know, when we did the emergency debate on opioids last year or a couple of years ago, the study I read into the record was it's as easy as ordering a book on Amazon to get a kilogram of fentanyl. A kilogram of fentanyl, when something the size of a grain of sand could kill people. Now, I know our physician colleagues across the way could probably tell the ratio and the amount that is needed to put somebody under for surgery or to use the treatment for pain. But these are trained professionals. The people on the streets have no idea what it is that they're getting. You know, Mr. Chair, I went to an event in the summer, and I was driving a friend of mine from the event to another event, and just outside our homeless shelter, as we're driving by, there is we witnessed somebody being thrown out of a vehicle. And so as I do, I stop and tried to administer first aid. This young man, 20 years of age, 19 years of age, pants around his ankles, was literally tossed lifeless, like a castaway, onto the street because he'd been in this vehicle that turned out to be stolen. And they had, the occupants of the vehicle had taken a hit of whatever it was that they were, and he was in overdose. It was shocking for me that one of his friends on the street, another homeless gentleman, immediately knew what to do and was calling for the other people that were on the street that were gathered around for the naloxone or the Narcan, and he administered the shots to him. By the time the ambulance got there, we had given four shots, and he had not. We couldn't. He wasn't revived at this time. I was doing what I could, but it was shocking to see this, and I don't know the name of what was in it, but the ambulance attendants that came said they were seeing more and more powerful stuff. Benzos also laced in it. I don't even know what that is, but they said it was making it harder to bring these people back from the overdose. And going back to my brother, my brother has OD'd so many times that it takes more and more Narcan to bring him back from his overdoses. He's got apparently black marks on his brain, I guess, that cause seizures now and what have you. You know, I don't wish any of this on anybody, and I apologize for getting emotional last week. But the amount of people that I've sat with, the amount of families that I've sat with, I also do outreach on the streets in my community. I know we're all good people, and we all sign up to do better. Sadly, it seems that the partisan politics has taken over when many of us know better, and we know we should be doing something. Mr. Chair, this is about making sure our kids, loved ones, don't become addicts. Far too often, by the time they're addicted, it's too late. The addiction has a hold on them. We need to have policies aimed at preventing the spread of harmful and deadly opioids, not spreading through our streets. We need to be working on ways to get people the treatment they so desperately need, not perpetuating their addictions and creating more addicts in the process. Mr. Chair, I want to continue on the subject of the London Safer Supply Pilot Project, LIHC. LIHC's Safer Supply Program doesn't provide just free hydromorphone, also gives patients a comprehensive wraparound supports. That includes an array of health and social services, as well as access to an interdisciplinary team that provides counseling, housing support, and social services. The study provided no evidence showing that the provision of hydromorphone and not the plethora of accompanying supports were the cause of positive outcomes. Addiction physicians said this kind of oversight, wherein the benefits of wraparound supports appear to be misattributed to safer supply drugs, and is a common harm. It is common in the harm reduction world. The quality of the science is very poor, said Dr. Regan Streif, who also noted that the LIHC evaluation showed that some patients had dropped out of the program, but that no information was given about what happened to them. By failing to investigate these outcomes, safer supply programs can misleadingly reduce the death count. Patients don't die, they just disappear. As we know from our homelessness challenges that we have, these are the unaccounted for. These are people that, for many reasons, for whatever reasons, some on their own They choose to live on the streets. Some choose to live on the streets. Some choose for whatever reasons. And some just don't have the opportunity. But when they drop out of these programs, there's no recording of this. Dr. Regenstrief said that in general, many drug-related deaths are simply not counted if they're caused by something other than an overdose. If you're injecting fentanyl and then get a heart infection, or you die of something else related to drug injection while in the hospital, that doesn't get counted as a coroner's case. It's not necessarily considered drug-related. It's not being included with the overdose numbers, and the epidemiologists don't seem to be aware of this. I hope my colleagues across the way are paying close attention to this, Mr. Chair, and continue to pay attention as I read this next section, which is deeply disturbing. At least 4 addiction physicians I spoke to recently have witnessed firsthand that evidence which contradicts the narrative around safer supply is often dismissed. In some cases, doctors say they're pressured to ignore the harms. Dr. Regenstrief described being left out of important meetings, research activities, and conversations after raising concerns about safer supply. Dr. Violet used to work at a BC-based institution that is associated with safer supply, and as an addiction physician with a research background, the doctor asked to analyze the institute's safe supply data in order to track unintended consequences and potential harms. The request was met with hostility. They set up meetings with other stakeholders, and I very quickly got the sense that this was not welcome, said Dr. Violet. The institution refused to share its data, she says, and claimed that it already had plans to measure the potential harms of safer supply, but could not describe what those plans were. There was a very clear warning that Dr. Violet's job security was at risk by pursuing research that could reflect poorly on safe supply. In her words, it was quite clear to me that they did not want any outsiders taking part in their work. I'm not the only physician whose interest in this area has been met with opposition and challenges. After that incident, Dr. Violet found work elsewhere. Mr. Chair, what are these organizations hiding? What is this Liberal NDP government covering up? Could it be that they know their so-called safe supply policies are a disaster for Canadians, yet they still choose the politically expedient route instead of prioritizing Canadians' lives? It really is troubling, and it is a disgrace. I'll return to the same article, Mr. Chair, which goes on to discuss government inaction. Mr. Chair, I have a few pages left. Maybe we might want to dismiss with our guests, or do you want me to get through this? And then...
I think it's pretty clear that we're not going to get to 293 today. Would you?
In fairness,
that's as much a question as a statement, Mr. Doherty.
In fairness to our guests.
Okay.
And I'll do my best to be quick on the rest.
To our guests from the Public Health Agency of Canada, you're welcome to stay, but you're free to go. Thank you. And thank you so much for your patience.
Unless you want to stay and listen to me.
Yeah. Thank you for that, Mr. Doherty. Please proceed.
Mr. Chair, what are Canadian government bodies doing about diversion? As it turns out, very little. I emailed a list of diversion-related questions to Health Canada, BC Ministry of Mental Health and Addictions, and Ontario's Ministry of Mental Health. Both the BC government and Health Canada replied. Neither answered my simple yes or no questions, either ignoring or deflecting them. Health Canada didn't mention any additional anti-diversion methods in its email, but said it will monitor and assess available information and take appropriate action where necessary. I then emailed Health Canada's response to over 10 addiction physicians. Those who replied were uniformly critical of the agency's recommendations, which they called inadequate and puzzling. According to Dr. Lamb, Health Canada seemed to be significantly out of touch with the realities of opioid use disorder and the market for illicit substances, which is truly concerning. Concerning indeed, Mr. Chair. Clearly, if Health Canada can't even articulate a strategy to mitigate safer supply diversion, their government overlords have no inkling of how to address this crisis either. The article continued, to Health Canada's credit, at least it drafted a personalized response. When BC's Ministry of Mental Health and Addictions replied, it simply referred me to 2 documents produced by the British Columbia Centre for Substance Abuse. Several addiction physicians I spoke with said that both they and their colleagues who work on the front lines generally believe the BC CSU's guidelines, the guidelines, which are tremendously influential in Canada and Canadian addiction policymaking, failed to address the potential risks or harms of safer supply. Echoing his colleagues, Dr. Kahan said that Health Canada and the BC government researchers, public health officials, and harm reduction advocates have ignored these concerns and given funding of uncritical support for safer supply. The addiction physicians I have spoken with have consistently claimed that BCCSU uses inadequate research to support safer supply. This includes 3 former BCCSU staff members who spoke on a condition of anonymity for fear of career repercussions. Mr. Chair, enough is enough. Enough stonewalling, enough sidestepping, enough adjourning debate. The opioid epidemic is not an issue we can run from. There are lives at stake. Addressing this crisis is infinitely more important than partisanship. This Liberal NDP government must end its funding and support for these so-called safe supply programs now, or else pay them the attention they deserve and fix them. Clearly, the current system is broken. For the sake of our kids and our communities and our country, this committee needs to give the opioid crisis the care and attention that it deserves immediately. So, Mr. Chair, I've talked at length regarding these challenges and these documents, or these reports that we're seeing and we're hearing. It seems like every day you honestly cannot turn on the on the news or look at social media. Well, maybe not social media anymore because you can't get news on there. But the stories, and I don't know about my colleagues, but my inbox, whether it's my social media inbox, whether it's comments on posts, or my email, or my offices, phone calls, we have so many stories of yet another death related to opioid or fentanyl. At one point, Mr. Chair, I spoke of this young player that I coached. His name was Chad Staley. Hopefully that wasn't a heavy sigh across the way as to yet another story for me, but Chad was an outstanding hockey player and community member, teammate. He was a young boy from I believe Kennewick, Washington. And when he came to our team, Mr. Chair, to play a junior for our team, he was just wide-eyed, bushy-tailed, just a true leader on and off the ice. And that translated into success, both on and off the ice. He was accepted. He had an NCAA scholarship. I believe it was in his second year of his scholarship. He was playing hockey playing in a game, had injured himself. And on the bus ride back to I believe it was his campus, one of his colleagues or one of his teammates had given, he was in so much pain, one of his teammates had given him a pill that they thought was like a T3 Tylenol with codeine. And Chad put it in his pocket, went back to his home, and at one point the pain was so much that he took the pill. That pill was laced with fentanyl, and you can imagine the shock and the horror of his parents that found their child, not a drug addict, not a drug user, passed away. That story is replayed over and over again. Maybe not a hockey player, maybe not somebody with a scholarship, but whether it's a blue-collar worker, whether it's a university, a president of a university or a vice president of a university in our province, two professionals on the island, a husband and wife, taking recreational drugs that died of an overdose from fentanyl. Or as I've been talking about with my motion, the increasing rate of deaths attributed to overdose in our homeless population. You know, last week I entered into, I talked about that if you don't believe me, at least we should believe the 17 leading experts in addictions medicine. You know, that's Dr. Mel Kahan, medical director for the Medify, co-chair of the Methadone Treatment and Services Advisory, Dr. Robert Cooper, board of the Canadian Society of Addictions Medicine, chair of the OMA section on addictions medicine, Dr. Paul Farnan. He's been in the field of occupational medicine and addiction medicine for over 25 years. Clinical Associate Professor, Department of Family Practice at the University of British Columbia, Dr. Michael Lester. He's a physician assessor at the College of Physicians and Surgeons of Ontario. Served as the secretary for OMA section on addictions medicine for 13 years. Jennifer Malamed, board of the Canadian Society of Addictions Medicine. Lynette Reeb. She is a clinical associate professor at the University of British Columbia. She's a physician certified in addictions medicine. Mary Durham Goodman, extensive experience managing addictions disorder. Dr. Mary Durham Goodman. Dr. Ray Baker, clinical professor at UBC, board of the American Society of Addictions Medicine. Dr. Harry Vitalago, chief of the Addictions Medicine Service at the Homewood Health Center. Dr. Alan Brookstone, addiction medicine and family physician, over 30 years of clinical experience. Dr. Clement Sun, founder of the ACT Addiction Clinics. Dr. Oded Samuel, over 25 years experience in the field of addictions medicine. Dr. Annabelle Mead, the medical director of BC Women's Hospital and Correctional Health Services. 20 years experience in concurrent disorders, pain, women's health, and youth addictions. There's a lot of people that have said a lot of things over the, both good and bad regarding my intervention last week. As I said before, if you don't believe me, believe these people that are the experts. And all I'm saying is that we have to be better, Mr. Chair. As I've said from the very first day that I've come to this committee and any other committee, and those that have been here as long as I've been elected, know that I always challenge us to be better when it comes to these issues, that we really, I truly believe that we can leave a legacy of action and not inaction. That's where I come from with this. I shared my personal story only not to gain sympathy, not to get likes on Instagram or Twitter or Facebook or social media, but just to say that, you know, well, I don't have the answers. I just know that we can be better. Our family lives it each and every day, and I appreciate all those that have come to me and shared their personal stories regarding loved ones and their own family challenges with addictions and mental illness, mental health. It truly is one of the toughest things to do, especially given this role that we're in, is to be raw and be vulnerable, to share that. I did not expect to be that emotional last week when I was sharing that story. It's something we live with each and every day. I expected to be but the reality is I get frustrated. I get angry. I get angry when we're sitting with these families, not just mine, but I get angry when we're sitting with these families that are crying and asking us to do something, and we're powerless. We're powerless to stop this drug from coming into our streets, into our communities, into our country. And for 8 years, I've listened to a government that says that we need to do better and be better, and yet here we are, still struggling with this. And the issue is not going away. It's not getting better. It's getting worse. And it's amplified by programs such as Safer Supply or Safe Supply. I will be the first to agree that there are many tools in the toolbox. And it is not a one shoe fits all or one size fits all. But this is not working. It's causing more problems. A whole new wave of the opioid addictions in our youth and young adults. It's plaguing our streets. And nothing's being done. We just go merrily about our way. I think that's mine, right? Thanks. I honestly wish we could have the conversation around the table with the cameras on. We've got expertise on all sides, and I know that they've experienced this in their professional lives. But I know what will happen is somebody from the other side will move to adjourn the debate rather than having an actual debate. And somebody will, I bet you there's something going on right now. Somebody's saying, well, the Conservatives are filibustering again and not letting our colleagues' private members' bill go through. You know, Conservatives are up to no good once again. And the chair's nodding his head. After all I've said, and I get that reaction, it's disappointing, Mr. Chair. And I know you to be a good person, but it is disappointing. Shake your head again all you want. It's disappointing. It truly is. Why can't we have a conversation about this? Why can't we do something about this? I believe there are good people on all sides of the House. I know it to be true because we have sidebar conversations with people that say that they feel exactly the same from all parties. Yet when we come through those doors or we go into the House, common sense goes out the door. I'm 8 years into this job, and I haven't been here long enough to be jaded. Although it may sound like it, I truly believe that there are good people on all sides. But if you aren't willing to fight for our most vulnerable, what are you willing to fight for? Why are you here? Truly, why are you here? We're sent here with a mandate to listen to Canadians, to fight for Canadians, to make lives better for Canadians. And I guarantee each and every one of our colleagues were asked when they were running for their nomination, they were asking people to vote for them for their nomination, are you going to toe the party line? But if this issue is really important to me and your constituents, how are you going to vote? And you can hear the echo of the whip crack. Aren't committees supposed to be the masters of their own destination? That's what I hear from the Liberals all the time. Oh, I had nothing to do with it. Oh, committee's free to do whatever they want. Well, if we're free to do whatever we want, then let's do this study. Heads down, checking their emails, texting, shaking their head, laughing.
Point of order, Mr. Chair.
I still have the floor,
Point of
Mr.
order.
Chair.
Yeah, and point of order takes precedence. Go ahead,
Respectfully,
Mr.
nobody's laughing, nobody's smiling. Everyone is listening intently all night long. Thank you.
I agree. Go ahead, Mr. Doherty. You still have the floor.
Right. Mr. Chair, I'm close to wrapping up, so people can breathe a sigh of relief for now. But I will tell you this, I will continue to push. I will continue to push and fight for those who are our most vulnerable, whether they are homeless on the streets, whether they are our youth that are becoming addicted to opioids, whether it is the families that have been left behind to pick up the pieces. I commit to you, if you're listening to this, that I'll continue to fight for you, and I'll continue to fight until our colleagues in the Liberal NDP coalition actually stand up and agree to doing this study and truly finding out how we can make things better for those who are struggling with addictions. Thanks.
Thank you. Next up, Dr. Ellis, and just so that people know, there are three people on the speakers list, and now 4 people, sorry. Dr. Ellis, then Dr. Hanley, Mr. Davies, and then Mr. Theriault. So, Dr. Ellis, you have the floor.
Well, thank you very much, Chair, and I want to thank my colleague for his incredible hard work on this topic, and I think that everyone around this table would realize clearly that this is a topic that is incredibly emotional for my colleague, both because of the fact that he has a heart as big as my grandmother might say, all outdoors, but also because it's very personal to him as well. And I want to thank him for not only sharing his passion, his personal story, but his advocacy for those who sadly don't have a voice here themselves. And I would echo his comments that realistically, that is what we're all here for. It's interesting, colleagues, that oftentimes people wonder, why is this important to us? Why are we fighting about it? Is there a plan to deal with it elsewhere in the calendar, or those kinds of things? And when you look back to the study, which I know our colleague from the NDP was here in 2016, Ms. Sidu was here in 2016 when this issue came before the Health Committee, and we know very clearly that, just looking very simply at the statistics at that point in time, that there was, it was astonishing to the committee at that time that there was a death every 3 days due to opioids at that time, due to opioid overdose. So that was 2016. Here we are, 8 years. After 8 years, what we know clearly now is that there are more than 20 deaths a day. We've gone to a death every 3 days to more than 20 deaths a day. And should that seize this committee? Back then, a death every 3 days was an opioid crisis. Now we have 20 deaths a day, and I wish I were a wordsmith and could tell you what the superlative of an opioid crisis is, but I don't know that there is a word that could even describe what we now exist with, 20 deaths a day, 20 plus deaths a day. And why is it also important? You know, people will say, well, you're politicizing this. Well, it's partly a political issue, I'm sad to say, because of this issue of safe, whatever you want to call it. Let's just call it what it is. It's government-funded supply. And when we look at that, my colleague raised the good point about homelessness and addiction and services that are or not available. But very clearly, you often wonder which came first, the addiction or the homelessness, the homeless or addiction. We could argue that for days here. I think the one thing, though, that we as conservatives wish to bring forward is that issue, which is, of course, intimately and integrally related, is that issue of government supply of hydromorphone on the streets. And we know very clearly, as my colleague mentioned, that many addiction medicine experts out there are absolutely and totally against this concept. And I think what I'd like to outline this evening for everyone and for the millions of people out there who've joined us is the words that should bookend the story that I'll tell in the middle, but the words of addiction medicine specialists who talk about safer supply. And I do want to read this letter from a physician that my colleague referenced. His name is Robert Cooper. I asked him for permission to use this. This is an email to the Minister of Addictions and Mental Health. And what it says is, on a daily basis, we are seeing opioid-dependent patients relapsing on inexpensive and widely available diverted hydromorphone from safe supply programs. My colleague presented some pictures of pill bottles from safe supply programs. We are seeing this lead back to fentanyl use and then to overdose deaths. We are seeing many people with no history of opioid dependency starting new addictions with diverted hydromorphone. So here we are with this lame idea, and I'll come to why I called it a lame idea, that giving people free drugs is suddenly going to help them not be addicted. And not just free drugs, but free drugs in an unsupervised manner. We certainly know from significant clinical use of opioid agonist therapy, which is the supervised reduction by a healthcare professional in the amount of opioid that an individual is using, can be beneficial in the treatment of opioid use disorder. And I think that everyone would agree that that makes sense. But to give people an opioid, and you know what, I know I've probably said this at this committee before, I know I've said it in the House of Commons, but 8 milligrams of hydromorphone. Now, people will often look at a pill, and an 8 milligram pill of hydromorphone will say, well, it's just a pill. It's the size of an Advil or a Tylenol. How possibly bad could it be for people? And we know that it is incredibly potent. And I'll come back to its potency when we continue on with this sad tale. The letter from Dr. Cooper goes on to say, and this is bolded, colleagues, this is not harm reduction. It is harm. This is not safe supply. It is reckless supply. Reckless. This is a reckless way to go about trying to, I don't know what the original intent was. I hope the original intent was trying to help folks with opioid use disorder. But when you have experts in the field out there ringing the alarm bells loudly and repeatedly, then I would suggest that this government, which appears to be hell-bent for leather in continuing safe supply for unknown reasons. And why do we say that? Well, we had the former Minister of Mental Health and Addictions here, and I can remember very clearly talking about dosages of fentanyl. And when we talked about dosages of fentanyl, we talked about that in this decriminalization experiment, we heard that you could, for personal use, have 2.5 grams of fentanyl. And we know very clearly that if we were to work in an emergency room, perhaps do a reduction of a dislocated shoulder, that you might get 100 micrograms of fentanyl. And we're talking about 2.5 grams of fentanyl. And I said, well, that's enough to treat 25,000 people. And the retort from the minister at that time was related to saying, well, it's always cut with something. You know what? It's interesting. I looked at what the Government of Canada website had to say about fentanyl, and it's quite fascinating. This is the Government of Canada website about fentanyl. Fentanyl is a very potent opioid pain reliever. A few grains can be enough to kill you. A few grains. And we have the Minister of Mental Health and Addictions suggesting that 2.5 grams is an okay amount to have for personal use. It's used in a hospital setting. A doctor can also prescribe it to help control severe pain, yada, yada, yada. And here we are continuing on this fight, and people say, well, why now are you interrupting a study on pandemic prevention and preparedness? Well, first of all, and mainly because this topic is killing Canadians. And if we as a health committee are not seized with that, and we as the opposition are not seized with calling out a government which is clearly doing the wrong thing and allowing the death of its own citizens, such that there is now a framework for people with addictions to be able to kill themselves by medical assistance and dying. Not only is this Liberal government wanting to kill Canadians who have depression, but now they want to kill Canadians who have addiction. Now, is that simply because it's easier? Is that easier than treating them? Well, you're trying to kill them now by giving them the amounts of opioids for free in a quote-unquote safer supply program. But now we are going to have a society based on a framework endorsed by this government
Point d'ordre, Monsieur le
to
Président.
say that
Point of order?
them
Excuse
to
me,
be
Dr. Ellis.
killed.
We have a point of order from Mr. Theriault.
Oui, ça va permettre à Monsieur Ellis.
Yes, I'll give Mr. Ellis a moment to catch his breath. Mr. Chair, it is 10 to 9. You mentioned that there are people on the speaking list. Usually, when we know that there's a speaking list, we agree of a speaking time for everyone. Because I would like to discuss with Mr. Doherty, but they've been monopolizing the time for about almost 2 hours. Perhaps it would be good if you could propose to members a way for things to work for the next until the end of the meeting, so that people who have raised their hands can speak. There are no longer witnesses here. The schedule is out the window, and I think that people should be able to speak. I can propose that if you'd like. There are, 3, 4 people on the list? Mr. Chair, how many are there? How many people on the speaking list? I think I heard that there were 4. And how much time should they have? 10 minutes? Yes, there are 4 people. That is something I can propose, Monsieur Thériault. But Dr. Ellis has the floor. Inaudible. It is his choice. It's not our choice. That's why I brought it up. Because we would like to be able to work hard here. If he wants to take this time, he can. You suggested it, I can suggest it, but he has the floor for as long as he wants.
Thank you very much, Chair. And to my colleague, we can continue this debate for as long as it takes. And that will also absolutely give you the opportunity, sir, to have your say on this important topic. I have no issue with that. However, I do think it's clear that the issue at hand is related to the fact that we have raised this particular issue of opioids multiple times in this Standing Committee on Health. And what has happened? What has changed? Absolutely nothing. Nothing has changed. And what we see is colleagues continuing down an incredibly dangerous path for Canadians. And as I said, and I need to hit the rewind button for a minute, because let's underscore what's happening here. Not only are 20 plus Canadians dying a day, but this Liberal government, their MAID regime, which is set to take effect mid-March of 2024, to allow people with depression to be killed at their hand, that further to that, now there is a proposed framework to allow people with addictions.
Point of order, Mr.
Which is
Chair.
interesting that I continue to get interrupted, Chair, when we're talking about an incredibly sensitive part here. Fascinating.
It's a point of order from Dr. Hanley.
Discussions about MAID and allegations about the purpose of MAID are not relevant to this discussion.
Of course they're not.
I'm not so sure. I do see the link between opioids and medical assistance in dying, and I think if we get too far into the MAID discussion, there could be a point to be made with regards to relevance. I'm not sure we're there yet. Dr. Ellis, go ahead.
You know what? I know that there is. It's fascinating to me that the former Liberal speaker, I don't know if that's the right term, he certainly was elected as a Liberal, is talking about decorum. And what do we have over here? We have people, when it becomes uncomfortable, we have colleagues of mine who know that this is an incredibly important and difficult topic, wanting to interrupt. I think that is a bit baseless. It is juvenile and incredibly inappropriate that we don't want to talk about the issues that we know that are being brought forward because of the policies of that Liberal government. We know it. Everybody here knows it. And you know what? It's uncomfortable and it's painful and it's unpleasant, yada, yada, yada. Too bad. Because Canadians are now uncovering the abscess that is existing in their own country, which is that Liberal government, supported by these members across from me where I'm pointing. And they need to grow up and decide what side of history that they want to be on. That's their choice. As I was saying, the MAID regime, which I sadly had to sit through as a member of Parliament, sadly because oftentimes it would appear to me that there was a gleeful nature of the Liberals as they brought forward more and more abilities for Canadians to kill themselves. And what we saw there very clearly is that depression is in its infancy in terms of diagnosis and treatment, and now we will have a regime in this country which is not supported by Canada's psychiatrists, and we know that very clearly. But there is one psychiatrist on that committee who continues to push forward that agenda. And now what do we see? We see other folks who want to take advantage of that and suddenly say, hey, you know what? People sadly are addicted to drugs. Let's let them end their life. My colleague here has an interesting article of pictures of people who died of overdose and pictures of them as children. And everyone around this table knows, and anyone who's listening out there knows, that there is no kid in this country who grew up saying, I wish that when I grow up I was addicted to drugs. And that this safe, government-sponsored hydromorphone doling out for free program is allowing them to continue on to be addicted to drugs. And that is a very, very, very sad state of affairs in this country, and especially when, I don't even know how many Liberals there are in the House of Commons, there's too many, I know that, is that they know the difference and they refuse to stand up and be counted and understand that this is an incredibly slippery slope that we are going down. Not only are we now providing drug addicts with drugs for free that we know are being sold from the investigative reports of people like Adam Zivo, and also from physicians who my colleague named, letters that they've sent to this government, other physicians who are too afraid to come forward because they're afraid that their professional reputations will be sullied by this Liberal government. And we continue to allow this to happen. Shame, shame, shame. That's what I say, shame. Back to this original letter that we heard, that we have received from Dr. Robert Cooper, which was sent to, again, the Minister of Addictions and Mental Health. It is reckless for people suffering from addiction, as it is not supervised to ensure it is taken safely in the manner intended by the manufacturer and is provided in a way that can be and is being sold with the funds utilized to purchase even more potent and dangerous opioids such as fentanyl, which we hear this is the enemy. It's a toxic supply. This is what the Minister of Mental Health and Addictions came before this committee before and said, this is a dangerous drug, it's toxic, but you know what? If we give them something else, then they'll stop using fentanyl. We know that sadly, that is the high that people who are addicted to drugs want. They want a high from fentanyl. And all they are doing very simply is taking the hydromorphone that is being supplied for free and selling it to kids and other people who have never used opioids before, and they are then buying fentanyl with it. This is not a great stretch of imagination or fantasy or the unicorns and fairy dust that we hear from this Liberal government on other topics. This is fact that is being reported from people who work in the system. This is being reported by people who use the drugs on the street. Why do I say it slowly? Because it appears that is the only way that it can be heard by my Liberal colleagues. Why is it that we need to talk forever in this committee to get anything through? Because otherwise, there'll be a move to adjourn the debate on this, which we have already seen. I shall continue. It is provided with a reckless disregard for our communities, as it has increased the availability of high-potency pharmaceutical-grade opioids on our streets, increasing the number of people suffering from addiction. They are seeing more people. These are addictions experts. This is what they do. They are seeing more and more people coming and saying, wow, I have a problem with drugs. And guess what? I had free hydromorphone supplied by the government. Or I got the free hydromorphone supplied by the government, and guess what I did with it? I sold it. I sold it and bought something else with it. Now, selling it, you know, are they buying more fentanyl? Probably. Are they trying to live because of the incredible, crushing inflation and cost of living crisis that this Liberal government has created by the reckless spending? Yes, they are. Of course they are. If they can't afford to put a roof over their house, over their heads, the likelihood, of course, of them being addicted to opioids is probably greater. And if they are addicted to opioids, it is much more difficult for them to put a roof over their heads. Can they feed themselves? Not well. Can they heat their homes? Well, they don't have any homes to heat. We know that very clearly. And so continuing on punishing and punishing and punishing Canadians is what this Liberal government is bent on doing with their NDP coalition partners. Thirdly, it is reckless in the complete failure of monitoring, supervision, and an abrogation of responsibility for doing so with an apparent reliance on the criminal justice system to prevent diversion, when it is widely known that the criminal justice system has already failed to prevent the sale of opioids during the current opioid epidemic. Colleagues, one of the things I think that's important that we begin to understand is how related this epidemic that we have is to the OxyContin crisis. Now, we know very clearly in popular literature, and if you're not a student of history, that looking at Netflix, there's a series called Painkiller, but we know very clearly that this tragedy that exists on Canadian and American streets at the current time is realistically related to the promotion and marketing of OxyContin. And there's an interesting article in the American Journal of Public Health, and it is entitled just exactly that, The Promotion and Marketing of OxyContin, Commercial Triumph and Public Health Tragedy. Public health tragedy, and this, of course, public health tragedy continues on. And we know very clearly from this article, it talks about controlled drugs, and it has an American flavor to it, and certainly it's not a style that we talk about in Canada, but we talk about opioids, and certainly realistically they are controlled drugs in terms of how they are supposed to be prescribed and given out in a very, very controlled manner by responsible physicians, by those who need them, which we now know as a cautionary tale is not very common. But this article starts with controlled drugs with their potential for abuse and diversion can pose public health risks that are different from and more problematic than those of uncontrolled drugs when they are over-promoted and highly prescribed. Well, we have an asinine situation now where these drugs are not only not prescribed, but they don't cost anything. So they're not just highly prescribed, they're highly given out. You can't even, there is no place in the world that anyone could possibly fathom that not only are these drugs, which we know clearly are dangerous and should be controlled, but are now being given out by this government. And what did I say previously about fentanyl? We talked about fentanyl. What makes it so dangerous? This is from Canada.ca. It is 20 to 40 more times potent than heroin and 100 times more potent than morphine. This makes the risk of accidental overdose very high. Now, realistically, we know that hydromorphone is a little less potent than fentanyl. Understandably, it is dosed in milligrams, not micrograms. So we know very clearly that is very different. I understand that. But that being said, for those who don't partake in opioids or haven't had the need to use opioids, we know that these drugs are incredibly dangerous. And not only are they now highly prescribed, they are just given out. They are given out for free. How does that make any sense? And when we look at this, this talks about an in-depth analysis of the promotion and marketing of OxyContin, which is also known as oxycodone. We know that when Purdue Pharma introduced OxyContin in 1996, it was aggressively marketed and highly promoted, and sales grew from $48 million in 1996 to $1.1 billion in 2000. And the high availability of OxyContin correlated, listen to this, The high availability of OxyContin correlated with increased abuse, diversion, and addiction. And by 2004, OxyContin had become a leading drug of abuse in the United States, and certainly not different in Canada. So that's in 2004. It had a $1 billion market in 2000 in the United States, and in 2004, it had become the leading drug of abuse in the United States. 2004. Now that's 19 years ago. So 19 years ago, everybody, it seems, knew that OxyContin was a leading drug of abuse in the United States, and here we are decriminalizing, not just decriminalizing drugs in this crazed experiment, but we have a government which is giving out opioids, exceedingly potent opioids, for free. They're giving them away. Now, if anyone out there could possibly make any sense of the fact that we know that what happened as a cautionary tale with OxyContin, oxycodone, beginning in the United States and having the trickle-over effect into Canada, and now we have a government who seems to, I can't even, it defies my ability to understand how a government could possibly think that then giving it out for free, its cousin out for free, would help an addiction, an overdose death, and homelessness, and affordability, cost of living crisis get any better. That does not make any sense at all. It is mind-boggling, mind-numbing, without any ability for me to understand that. And this article continues. It goes on and it talks about, under current regulations, the Food and Drug Administration is limited in its oversight of the marketing, promotion of controlled drugs. However, fundamental changes in the promotion and marketing of controlled drugs by the pharmaceutical industry and enhanced capacity of the FDA to regulate and monitor such promotion can positively affect public health. So what we're talking about here is asking then a pharmaceutical industry to change how these drugs are promoted and regulated. And what we have come to is a government which effectively has deregulated, unregulated, dysregulated, totally and absolutely gone against regulations, and not only is not just promoting a potent opioid, but is giving it away for free. Giving it away. So it's not even, you think about it, if I had a product, why would I need to promote it if my objective is simply to give it away? I don't need to promote it. I'm giving it away. So we have on one side, a government realizing in the United States that pharmaceutical industries need to be more regulated with their promotion and their regulations around opioids, and we have a government north of the border giving away opioids and suggesting that in land of unicorn and fairy tale dust that this is making an opioid, again, the superlative of crisis, better. Mind-numbingly, without any ability for me to understand that. When we go on and we begin to understand that because some people will say, well, you know, this is not related to hydromorphone or fentanyl. And this article goes on and it talks about OxyContin's commercial success did not depend on the merits of the drug compared with other available opioid preparation. The medical letter on drugs and therapeutics concluded in 2001, now here we are 22 years ago, that oxycodone offered no advantage over appropriate doses of other potent opioids. So for people out there to say, well, you know, hydromorphone's better than fentanyl, is better than oxycodone, clearly we know that in esteemed and useful and well-read medical journals that is absolute and total hogwash, that there is no difference amongst these opioids at all, and that they are all incredibly, incredibly dangerous. So where does that leave us? Well, that leaves us again when we look at this, and I'll continue on. There were some other things here that talked about the potency and relative potencies, and I think I'll leave that out, but I may come back to that. The promotion and marketing of OxyContin occurred during a recent trend in the liberalization of the use of opioids in the treatment of pain, particularly for chronic non-cancer related pain. Purdue pursued an aggressive campaign to promote the use of opioids in general and OxyContin in particular. In 2001 alone, the company spent $200 million US dollars in an array of approaches to market and promote OxyContin. So when you begin to look at that, it became very, very clear, and I was a practicing physician during those days, and I remember clearly many edicts coming out from the Canadian Medical Association, the Canadian College of Family Physicians, and I'm not entirely sure, but probably the Canadian Pain Society, suggesting that as someone who treated chronic non-cancer pain, that if physicians were not prescribing enough opioids to treat that pain, then they were bad doctors. They were bad doctors. And you know what? That was wrong. And we know it was wrong, but those of us who are physicians in this room know that that happened. We saw those edicts come out from the Canadian Medical Association, the Canadian College of Family Physicians, and as I said, probably the Canadian Pain Society, and we know that was wrong. We know in retrospect that was wrong, and there were changes that came forward that looked and talked to physicians about how they should prescribe opioids in a more responsible fashion. There was edicts also then subsequently that came out and talked about how much morphine equivalents of opioids should be prescribed, because we knew that these substances were being overprescribed in a highly regulated fashion already. But now what do we have? We have a government that is giving them away for free, that continues then to ignore their own advice, which says that these substances need to be prescribed very carefully in small quantities and for short periods of time. And now what do we have? We have a government that is giving them away for free in gigantic quantities for unlimited periods of time. Now, if that is not the exact opposite, I don't know what is. We have people getting 8 milligram tablets of hydromorphone in quantities of, it depends on which article you want to read from Adam Zivo, 26, 34, 32 tablets at a time. Now, if that is not big quantities of high-potency opioids given out in an unrestricted, long-term fashion, I don't know what is, which is the exact opposite of a careful, short-term, low-dose prescribing of opioids, which was suggested to physicians who should be controlling this. It is mindless, and it continues to this day. And folks around this table then want to say, why is it? Why do conservatives want to talk about opioids? Why do they want to talk incessantly about this? Well, you know what? Because clearly the Liberal government does not get it. Until we continue to say things over and over and over and over and over and over again, almost ad nauseum, then it clearly appears not to be understood. And you know what? I do know that one of my colleagues across and my colleague from the bloc referenced this, that there is a motion that has been, I don't know that it's been moved, but it's been tabled to talk about the opioid experiment. Well, you know what? If we had confidence on this side of this chamber that we're in this evening, if we had confidence that our colleagues would actually do the study, then maybe we wouldn't have to be here tonight talking about this over and over and over again. One of my colleagues even deemed this in this motion to be an opioid experiment. Well, you know what? When you have an experiment that has gone awry and is causing harm, every medical journal out there knows, what do you do with that experiment? You stop it early. That's what you do. You don't continue it on. You realize that people are dying because of the drug that you're using. You don't continue to do the experiment. You stop it. You stop the experiment. But oh no, what are the geniuses in the Liberal government doing?
Doubling down.
They are doubling down. They're doubling down. Let's fight the Conservatives on this. Because the Conservatives, and we heard this from my colleague this evening, we have those on the opposite side who think that this is a waste of time. That all we're doing is wanting to filibuster to get rid of Bill C-293. Really? Really? There's enough in Bill C-293 that we could have talked about it for 10 more years. It's a terrible piece of legislation. It's utterly ridiculous. It is fraught with incredible jurisdictional contradictions that my Bloc colleague would have talked about for the next 6 years, at least on his own. He brought an expert here to talk about Bill C-293 and talked about how bad the jurisdictional infractions were with respect to his great province of Quebec. And so now it is suddenly only the Conservatives who are trying to get rid of Bill C-293. C-293, you know what, I had an opportunity today to meet with the deans of the agricultural and veterinarian schools from across our great country. They have a huge problem with C-293. I read them sections of C-293, and I informed them that, yeah, we had one great meeting here with witnesses on C-293. They were aghast. They were aghast when you read sections of 293. And I told them that we had one meeting with witnesses. They couldn't believe it. To think that a bill wants to influence how the food that we eat and how it's produced here in this country, when we know that farmers are farmers are the greatest stewards of farmland and of farm animals in this entire country. And then we have the audacity of Liberal members to suggest that we are using opioids as a way to filibuster C-293. Hogwash. Hogwash. Petty politics. Absolutely incredulous. And so when I begin to look at the topic at hand, and which I will return to, understanding the scourge that opioids have caused for innumerable Canadians and continues to cause for innumerable Canadians, this is absolutely an unacceptable and an untenable position. We know, again, very clearly that the cost of living crisis that this government has created is continuing to cause significant problems for Canadians. And I would suggest to you that this opioid crisis is allowing this to be perpetuated. From 96 to 2001, Purdue conducted more than 40 national pain management speaker training conferences at resorts in Florida, Arizona, and California, and more than 5,000 physicians, pharmacists, and nurses attended these all-expense-paid symposia where they were recruited and trained for Purdue's National Speaker Bureau. It's documented that this type of pharmaceutical company symposium influences physician prescribing, even though the physicians who attended such symposium believe that incitements do not alter their prescribing patterns. So really, I mean, that's been a huge argument inside the medical community for a long time. But isn't it interesting, colleagues, that we're talking about here is how a company could influence the prescribing habits of physicians, and what we have now is these drugs being given out for free, and Liberal colleagues suggesting that that is an appropriate and acceptable type of behavior. We have, as I said, a scholarly article talking about that this is inappropriate. It's inappropriate to try to influence physicians who are the appropriate people to write prescriptions. It's inappropriate for them to be influenced to write more prescriptions, but it's not inappropriate for a government to give away the same drugs for free. Wow. I mean, I can't even wrap my mind around that would perhaps make any sense at all. It is absolutely nonsense is what it is. This article goes on and talks about how they possibly did this and how much money they spent to try to change physicians' minds and how many doctors that they convinced to do this and that they gave them fishing hats and stuffed plush toys and CDs. And when you look at this, now what are we doing? You don't need to influence doctors because the Liberal government is giving away opioids for free. And then don't worry, Canadians, because when you're addicted to these opioids that this Liberal NDP coalition is giving you for free in their crazed experiment, what are they going to do? They're going to kill you. They're going to kill you. Nonsense. Absolute nonsense. To continue to allow the propagation of medical assistance in dying, the euphemism by which it's now become known from a procedure which was destined for those who had uncontrolled pain with a reasonable foreseeable death, now onto folks who have suffering because of homelessness, perhaps, because they can't find a job, because they can't afford a house, because of the 40-year high inflation of this Liberal government, because they can't afford to feed themselves, put a roof over their heads, and heat their homes for winter, because they are addicted to opioids, which this government is culpable in the creation of this problem. And now we are going to then say, let's make the problem go away. Let's simply make it go away. Because you know what the old saying is? Dead men can't talk. So let's let them go away and not be a problem, because we, not me, not those of us on this side, but this NDP Liberal coalition has created a problem which is uncomfortable, which I cannot understand why they want to continue to stand up and defend and not have the guts and the good decency to step forward and say, this is wrong. This is wrong. We made a mistake. And that's what grown-ups do when they make mistakes, is they admit they're wrong and they move on from their mistakes. And this country has trusted them to run this country for 8 long and miserable years. And what do we have? We have an opioid crisis that is beyond parallel. And I'll just go back to that number that I talked about earlier, that number went from 1 person dying every 3 days to more than 20 people dying every single day in this country due to opioids. And this experiment is continued to be perpetuated by this NDP Liberal government coalition, and they will not back down from their position. No matter what happens, it is very clear they won't back down. So when my colleagues begin to asking us why we need to continue to talk incessantly about a problem, because they don't get it. That is why. We know very clearly that the NDP member of this committee is a full-blown supporter of drug decriminalization, and the Liberal members have a boss in the PMO bent on safe supply, and that makes me really able to understand why they're reluctant to talk about this topic. We look at Mr. Davies' provincial counterparts, and the BC NDP is a prime example where tent cities and crime and chaos, drugs and disorder have become the norm under their leadership, where drug overdose is now the leading cause of death for kids between the ages of 10 and 18. You know what, colleagues? I need to read that again. Where drug overdose is now the leading cause of death for kids between the ages of 10 and 18. I have 3 grown children. I have 2 grandchildren. This scares the daylights out of me. Because this is not just in Vancouver and Toronto and Montreal and Calgary and Edmonton and every other big city. This is in every town and village there is across this great country of ours. And folks, believe it or not, for roughly the past year, the Prime Minister and the leader of the NDP authorized the BC government to allow crack, heroin, cocaine, and fentanyl around children's playgrounds. And they had to then create another edict to say that, oh, suddenly, you can't have these drugs around playgrounds and areas that children frequent. Are you kidding me? Crazy. That we think that this is suddenly an acceptable part of Canadian life that these drugs are around where families and children are all the time. And it took a year before an election for them to recently walk this policy back before finally prohibiting open-air drug use around these areas. Shame. Finally. And colleagues, we know that this happened within the last 1 month. Within the last month. We know that this happened within the last month. Wow, you shouldn't use drugs around kids. Shameful. Shameful. And you would think after 8 long and miserable years of this Liberal government that there would be a change of heart. Well, you know what? I know very clearly that there is not a change of heart. Because tonight what we saw was the incredulous activities of colleagues on the opposite side in the NDP Liberal coalition suggesting that this was a simple ploy by Conservatives to get around Bill C-293. Bill C-293 is a ridiculous piece of legislation that allows this Liberal government to not have an inquiry with respect to their pandemic response. And as I said, it creates incredible jurisdictional difficulties related to attempting to force Canadians to change how they farm this great land and how they produce protein for Canadians, and how we you know what, it's interesting. Again, I'll go back to the deans of agriculture and veterinary colleges today, and you know what? They know, and they've said this out loud, that Canada could be the entire breadbasket for the world. And what do we have? We have the NDP Liberal coalition wanting to stand in the way of that. That, oh no, farmers are mean people. They're mean to their animals. They are mean. They're mean. They don't know how to take care of animals. They haven't done it ever. That they are bad stewards of the land. That they're overusers of fertilizers. That they are unknowledgeable in practices of farming. Really? We really want to believe this? Shocking. It is incredibly shocking. And the NDP Liberal coalition, my friends, this is the track that they want you to go down. This is the track that they want Canadians to begin to believe that farmers are bad people. I know a lot of farmers. They are not bad people. They are perhaps the most optimistic people that I have ever met. To be a farmer, you have to be optimistic. Who could possibly think at the beginning of every growing season that you would say then very clearly that I'm going to have enough rain and enough sun?
Point of order from Mr. Davies, please.
If I'm not mistaken, we're debating Mr. Doherty's motion on opioid overdose, and yet Mr. Ellis has strayed back, ironically, to the actual item on the agenda, which was supposed to be Mr. Erskine-Smith's bill on pandemic response, which did deal with some of the issues that Mr. Ellis is speaking about. So I think he needs to be called to order and to confine his remarks to the motion under discussion.
Thank you, Mr. Davies. Dr. Ellis, you are wandering from the topic. I don't see the connection, but it's been a long address. It's understandable, but if you could focus in and just while I have you, a couple of times there you banged the table, and we got a note from the translation folks that didn't feel very good. You haven't done it in the last 10 or 12 minutes, so I didn't get a chance to come in there and mention it to you. But you still have the floor. We have about 1 minute left in our allotted time. You have the floor, and at any time at 9:30 or later, a motion to adjourn would be in order. Go ahead, Dr. Ellis.
Thank you very much, Chair. And my deep apologies to the translators. You know, the passion, I'm afraid, overtook me, and I apologize deeply for that. You know, that being said, you know, why did I wander back to the bill at hand? Because there were accusations around this table that said that this was a filibuster to get rid of Bill C-293. C-293, I would love nothing more than continue to talk about C-293. Sadly, there's something that is way more pressing when 20 Canadians a day are dying, 20 plus Canadians are dying because of a failed NDP Liberal coalition experiment. That unfortunately, the NDP, who believes to be the arbiter of this committee, continues to want to interrupt, even though perhaps if he paid closer attention to the incredibly important words that I'm saying, he would understand the connection between the injustice attempted upon the Conservatives in suggesting that this was a filibuster related to C-293, and that is why I needed to make that connection to the matter at hand related to homelessness and ongoing opioid experiment, which is continue to be perpetrated and propagated and perpetuated by the petulant Liberals. And that causes great consternation for all of us who sit on this side, the Conservative side of the House. What we know very clearly is that safe supply is a failure. It is a failure. It is an abject failure. And it doesn't matter what euphemism that we wish to say about it. We want to call it safe supply or safer supply, safest supply, whatever other, again, those are the superlatives we have at our use in the English language. Whichever one we want to use, we know that is an experiment and we know that it has failed. And we know very clearly that this is a lesson from history. And not to be too trite, but we know that those who refuse to listen to know history, or to believe history are doomed to repeat it. When we look back at the Purdue Pharma fiasco, the tragedy as mentioned in this article, we know very clearly that Purdue Pharma misrepresented the risk of addiction. And as this article talks about, there was a systematic effort to minimize the risk of addiction and the use of opioids for the treatment of chronic non-cancer related pain. One of the most critical issues regarding the use of opioids in the treatment of chronic non-cancer pain is the potential of iatrogenic addiction. I'll come back to that. The lifetime prevalence of addiction disorders has been estimated at 3 to 16% of the general population. So when we look at that, what does that mean? That means that for those being prescribed opioids for chronic non-cancer pain, that even giving them opioids, there was a likelihood that they were going to become addicted to them. And now what are we doing? We're not, again, at the current time, this NDP Liberal government is not prescribing them carefully in small quantities and in small dosage amounts. They are giving them to them. They are giving these medications to Canadians for free in large quantities of an incredibly potent opioid called hydromorphone. And when we look at that, colleagues, that is the anathema to what is the suggestions after the historical tragic events related to Purdue Pharma, that we all need to hear the lessons thereof, such that we are now doomed to repeat them, and that is exactly what we shall do. And Mr. Speaker, Chair, if I may, just may I have a point of clarification, Chair, if I might. If I agree to adjourn this meeting, will I still have the floor when we pick it up next time?
Not necessarily an adjournment of the meeting. Actually, at the next meeting, we have, I believe we have witnesses. So if we adjourn the meeting, basically we would proceed with the agenda for the next meeting. So unless this was actually on the agenda, it wouldn't be automatic, Dr. Ellis. And we are at the point, Dr. Ellis, where we're at risk of losing our resources. So a motion to adjourn would be a good idea, regardless of the consequences, because soon we're not going to have the support that we need to continue.
Well, Chair, you know what? I believe that this topic is absolutely essential to the Canadian narrative at the current time. And for that reason, if you would like me to stop, I'm happy to hear you say that, because I don't want to give up the floor and I do want to continue on with this, Chair.
Okay, thank you for that invitation, colleagues. We will not have resources to go any further, and is it the will of the committee to adjourn the meeting?
No, suspend.
Motion to adjourn is not debatable. Is it the will of the committee to adjourn the
Point
meeting?
of order, Chair. Point of order. I
Go ahead.
actually didn't hear a motion to adjourn this meeting.
Oh.
I did hear the chair talk about adjourning the meeting, but there was no motion to adjourn. I believe, if I heard correctly, I did have a motion to suspend the meeting from my honorable colleague.
All right, there isn't a motion to adjourn before the committee. I invited one and didn't receive one. It appears that there is a motion to suspend. The committee is scheduled to meet next on Monday morning. So is it the will of the committee to suspend this meeting until Monday morning at 11 a.m.?
Point of order, Mr. Chair.
Go ahead.
I
Dr.
did not hear a motion to suspend.
Yeah, I did. Dr. Kitchen moved a motion to suspend.
But Dr. Kitchen, excuse me, but
Yeah,
I don't believe Dr. Kitchen had the floor,
Oh, yes.
Mr. Chair.
Yeah. Dr. Kitchen didn't have the floor. You are correct. Dr. Ellis has the floor, and Dr. Ellis still has the floor.
Motion to suspend, Chair.
Now we have a motion to suspend that is in order. Is it the will of the committee to suspend the meeting until 11 o'clock on Monday morning?
Point of order, if there is no suspension, what's the alternative?
That's not a point
They-
of order, that's a point of clarification.
Yeah.
We need to rule on this, Chair, I suggest.
Yeah.
Point of clarification.
Well, we're left in the untenable situation of trying to continue with the meeting without having resources. So, and in the absence of a motion to adjourn, that's where we're left. And quite frankly, I don't want to be there. So we do have a valid motion to suspend before the committee. The question's been put. All those in favor of suspending the meeting until 11 o'clock on Monday morning, please raise your hand. All those opposed? Okay, I think we're going to need to take a count here. We've got four in favor, 1, 2, 3, 4, 5, 6, 7 opposed. So the motion to suspend is defeated.
Mr. Chair, I
Well,
have my
thank
hand
you,
up to be
thank you very much,
recognized.
Chair, and I appreciate the fact that I do still have the floor.
Hang
so
on, Mr. Davies, did you have a point of order?
No, I had my hand up for the floor. Dr. Ellis no longer has the floor because he just moved a motion to suspend that was defeated. So I had my hand up to be recognized.
Okay, well, thank you. I'm going to take advice on whether the floor goes back to Dr. Ellis, but what I can say is that next on the speaker's list after Dr. Ellis is Dr. Hanley. Just bear with me for one. But Dr. Ellis, we're going to lose interpretation very quickly, and we're not going to be able to carry on with the meeting, and I am going to exercise the power to adjourn the meeting because it's impossible for us to continue. So I therefore declare the meeting to be adjourned.